let me get started introducing our wonderful guests. Thank you all for bearing with us. All right, first of all, on the screen over here, we have Dr. Olivia Musilli. I feel like I didn't actually ask you how you pronounce it. Musilli?
That's perfect. You got it. Musilli.
Okay. She graduated in 2017. And by the way, she majored in English, and I just want to point out that all three of these ladies majored in English, and Sharon Hickson emailed me, and she was like, we must be doing something right. So Dr. Musilli, her summers were spent fulfilling science and math requirements for the MCAT, which is the admissions test you have to take to get into medical school. She was accepted into Lake Erie College of Osteopathic Medicine in 2018 and graduated in 2022. She is currently working as a second-year family medicine resident at Meadville Medical Center in Meadville, Pennsylvania. She is interested in specializing in addiction medicine, and in her free time, she enjoys visiting her family and playing her ukulele. So we're very glad that she could join us, even though it's virtually. I know it's a little bit. She'll have so much great stuff to share with us. All right, next we have Dr. Emily Janaro, who graduated in 2019. She attended Shenandoah University, where she received her doctorate of physical therapy in 2023. She currently works as a physical therapist for Valley Health at an outpatient location here in Front Royal. She treats a variety of musculoskeletal and neurological conditions from infants to older adults, and her job also requires her to occasionally cover here at Warren Memorial Hospital, which she finds very rewarding. Outside of work, she enjoys staying active and spending time with her husband and two beautiful daughters. So they could not be here tonight because of bedtime. And then finally, we have Rose Herlihy, who graduated in 2015. She went on to become a registered nurse at Mercy Hospital School of Nursing in Pittsburgh. She has worked in neuro and cardiac step-down units, which hopefully you can explain what that means. Spent a few years travel nursing, also please explain what that is, and now works as a clinical instructor here at Laurel Ridge Community College. Oh, you're in the Warrenton campus, okay, not Middletown.
Correct. Yes.
In her free time, Rose loves traveling and exploring, as well as staying home with a good book and a cup of tea. Don't we all? Okay, well, welcome, ladies. Thank you all so much for being here. And as you all know, we will chat for a little while. I'll ask them a bunch of questions, and at the end, you will have time to ask questions of your own. And we will have a microphone eventually, towards the end. So we will be good with that. Okay, so ladies, can you all start by telling us what led you to a career in healthcare? Rose, if you'll start us off.
Sure. Can everyone hear me okay?
Speak a little louder, yeah. You're good. You can keep it there.
Okay. How's that sound? Okay. All right. Let's see. So I think I wanted to be a nurse since I was a little girl because my little sister had a lot of medical problems when she was first born. She had Down syndrome and like multiple cardiac and respiratory issues. And my mom was a nurse, so she was able to get her through like over a lot of really difficult points in her early life because of her nursing background. So my little sister, for the first like 10 years of her life, she had a trach, which is an artificial airway. She had a feeding tube for like the first 5 years of her life, and like multiple other medical devices along the way that she needed. And so my mom was able to manage all that at home without her needing to be in a hospital all the time. She still was in the hospital a lot, and the nurses did so much to, you know, really get her through. She really almost died a few times, but she survived. She's really strong and healthy now. But a big part of that was my mom able to take care of her at home, and that was just such a good witness for me. So right away when I was little, I thought, oh, I want to be like my mom. I want to be a nurse, and I want to be able to save my little sister's life, you know. So that's what got me started. So I always knew I wanted to be a nurse. I knew I also wanted to go to Christendom. So I went to Christendom, and I got an English degree, and I loved it. It was amazing. And then I worked for a year at Seton Home Study School, and I saved up some money. And then I went to nursing school. It took me 16 months, and I've just been doing different things within nursing ever since. So that was kind of my background. I never like veered off my path and thought, oh, I don't want to be a nurse. It was always like there from the beginning, and I've always stuck with it, and I'm so glad. It's like the best decision I've made. So.
Oh, that's wonderful. Thank you. All right, Emily, tell us about you.
Well, similarly, my mom is actually a physical therapist as well, so I kind of had that inspiration from a young age, but on a different note, I didn't always know that that's what I wanted to do. I probably, like anybody, had about 50 different things: astronaut, marine zoologist specifically, so I could swim with dolphins, all the different things. By the time I got to Christendom, I was thinking, maybe I'll be an English teacher, but I don't actually know. And then I think sophomore year, my mom said, well, you could always come shadow at my work. And so I did, and I'm from Charlottesville, and she worked at an inpatient rehab facility there. So the type of PT that she worked in wasn't just, your typical sports clinic or just orthopedic injuries. It was a little bit more intense. It was people who had been really sick in the hospital and couldn't go home yet and needed intensive therapy at least 3 hours a day, 5 days a week. So what I got to see was people who had strokes, spinal cord injuries, complex motor vehicle accidents, really a lot of, really heavy duty stuff. And seeing them learn how to walk again, seeing them learn how to just, again, transfer, like the idea of transferring from your bed to the wheelchair is like, you think it's easy, but it's a really complex task if you've got an amputation or all kinds of things. So that really inspired me, and I went ahead and applied for a tech job there and worked there for 3 years, just getting to actually have some hands-on experience with these patients. You learn, okay, I haven't been to PT school, but how do I transfer this patient into the chair? How do I get them to the gym so that I can, they can be ready for therapy, get them dressed, take them to the bathroom safely? I got to do a lot of hands-on things that I was always amazed that they were letting me do. I mean, they were training me to do it, but just getting my hands on. And I always said that if I didn't want to be a PT after that, then I would have known. Because it was, again, it's very intense. It's not for everybody in that setting anyway. And then, so I was kind of on that path. I ended up graduating with my English degree. Again, I got my prerequisites during the summers. I did end up needing a few more after I graduated, so I took a year back home working as a tech and getting my last couple classes at community college for my prerequisites. And then the following year, started my PT program. And so since then, I've seen all kinds of settings, which I'm sure we'll get into a little bit more, different types of PTs that you're working with different populations. And I kind of discovered which genre and setting, I guess which niche that I wanted to be in. But overall, it was just kind of an exploration of, I want to teach, but maybe not a big classroom, maybe more one-on-one, and kind of helping coach people into doing functional things again, and seeing that I really get to impact their quality of life. So that was a cool journey for me.
Beautiful, thank you. All right, and Olivia, tell us about you. How did you get into medicine?
Absolutely. I just want to double check. Can you hear me all right?
Yeah.
Perfect. Okay. So yeah, those were awesome stories, but unlike Rose and Emily, I didn't have anyone in my family that was medical. I really didn't know too many doctors, nurses. So for me, it was more so in 8th grade, I was homeschooled. I did the Seton home study course. And so my 8th grade biology class, I just loved learning about like order and complexity, especially within the human body. And I wasn't exactly sure where that would take me. So at first I thought about PhD programs, and I thought, well, maybe I'll do something with cancer research. And then I talked to my own family doctor, and I talked to some other people that were in research, and I realized, I really like spending time with people. I'm pretty extroverted. So I was like, if I'm in a lab all day, I won't get to see that many people. So then I looked at some programs that were MD, PhD. So that's like where you are a medical doctor and you can still do the research side of things. And I was like, I don't know, that seems like a lot of work. You're doing, double the work for, and in schooling, and then later on in your career, you have to keep up with all that. And so eventually, I think it was during my time in Christendom, there were some doors that just opened that I never expected to open. And I talked to, again, my family physician, and I said, what do you recommend as far as like, should I go a pre-med route? Because I had heard of Christendom through friends, and I came to visit the campus. I did the summer program, and I loved it. And my family physician back home said, medical schools are really looking for well-rounded people. So he said, I recommend you do something in the liberal arts or do something that's not medical related for your, before you go to medical school if you decide to go that route. So I came to Christendom, also majored in English, graduated in 2017. I took that next year and I studied for the MCAT. I applied to medical school. I did a shadowing program at our local hospital, and then I was also working in youth ministry to earn some money that year. And then I applied and got into LECOM and graduated from there in 2022. And I applied to family medicine residency, and that's where I am. I'm in my second out of 3 years of residency. I absolutely love it. I love the variety. Yeah. I guess that's the story of how I got here.
So why don't you go ahead and continue talking about the schooling that you went through, and you didn't mention doing any prereqs, so tell us about that. Did you have to take any? Because some of the research I've done with some of the students actually sitting in here about med school, UVA doesn't require any prerequisite classes, but you have to be able to pass the MCAT. And so in order to pass the MCAT, you have to understand physics and biology and microbiology and all this kind of stuff. So I'd love to know, Olivia, a little bit more about what kind of prereqs you did to get into school.
Well, that's wild, because when I was applying, there were certain prerequisite classes, and they did want you to have some like humanities, and they wanted you to have an English class and stuff. But that's good to know that they're not necessarily requiring those courses. I was able to fulfill some of those at Christendom. I took physics 1 and 2 with the labs. I was able to do a directed study for organic chemistry at Christendom, and I did that with Dr. Garrigan. I don't know if he still teaches there, but he had a background in organic chemistry. Okay. Oh, okay. Oh, man. So he had a background, and so it just landed up working out where I was able to kind of design a course for medical school and get that prerequisite out of the way.
Wow.
And I did it like an online lab thing. It was pretty crazy. But I also, in the summer, so summer between freshman and sophomore year, in sophomore and junior year, I took biology 1 and 2 with labs and chemistry 1 and 2 with labs. And then I didn't have to do any more prerequisites. So that year after I graduated from Christendom, I was just preparing for MCAT, and I got like an MCAT study series that I was using. There is a reading and comprehension part of the MCAT, I think, which I actually ended up doing really well on from the English background. But if I were to do it over again, I would recommend maybe getting a anatomy and physiology course in and a micro course. Those were the only two I kind of wished I had a little bit more background in. But I was able to get everything working those two, or studying those 2 summers in between, and then with my Christendom education, everything by then.
That's great. And so good news that you probably don't know about is that we actually have an anatomy and physiology course here with a lab. So it's a 2-semester class. I don't know how many people usually sign up for it. Miriam, do you know? 4 to 6? Okay. So yeah, so it's fairly new within it's fairly new within the past couple of years, but it's been a great addition, I think, for people like you who are interested in medicine, especially med school. So, all right, Rose, tell us a little bit about the schooling that you went through.
Yeah, same thing for nursing school. You really need a lot of those prerequisites to get into most programs. So, especially anatomy and physiology, you'll definitely need that at some point in your nursing schooling process. Doesn't matter what school you go to. So you need anatomy and physiology 1 and 2, micro with lab,
And microbiology.
Yes,
right? Okay.
Correct. Yes. Chemistry with. Do you have chemistry here? Do you have a college chemistry class?
We do have a chemistry class.
That's great.
Is it just one class that we have, or so far?
That's great.
More's coming. Yes.
Great. Statistics is usually another big prerequisite that's needed. So I think that a lot of those have been added in here at Christendom. So that's a big. That will really save you a lot of time. If you can take those while you're here, you'll be like all set then to get into any program that you like. I did a slightly different route. I graduated here and really didn't have any science courses behind me. I found a diploma program in Pittsburgh, Pennsylvania, where you didn't need the classes to, like, as prerequisites for the program. They let you start the program, and then you took the classes alongside your other nursing classes. But it was more difficult because it was lots of hard nursing classes plus all the hard science classes too. So it was just kind of a lot. So if you can get those out of the way, it will really save you like a lot of, you can just focus on your nursing classes once you get to the nursing program. The other option that a lot of people will do is to, they'll go to Christendom, get all those science classes done, and then there's a lot of accelerated BSN programs. Those are usually only a year, but they're really tight, really, they're really tough to get through. So again, if you can get all the science classes out of the way, then you can just focus on nursing. That's another great option. So you could finish Christendom and then just take one more year, and you could have your BSN. My program was great. It was really quick. It got me a diploma in nursing. So everybody who goes through nursing school has to, you go through school and then everyone has to sit for the same licensing exam. It's called the NCLEX. And once you pass your NCLEX, then you have an RN. So regardless if you have a BSN, an associate's in nursing, a diploma in nursing, everyone still has to take the NCLEX and you still become an RN. If you go to a community college, that's where I work now, is for Laurel Ridge Community College. You finish with an associate's in nursing, but that is still, that's perfectly adequate and acceptable to work at any hospital. You don't absolutely need to get more than that. The hospitals encourage you to get a BSN, but it doesn't change what you're able to do at your job. You might get paid slightly higher. That would be the only difference. And there might be more opportunities open to you if you want to go into management or, further your studies in nursing. But if the associate's degree is adequate to work in the hospital, so that's a great option too. The program, and this is the same across the board for nursing schools. Nursing school is really, really hard. It's the hardest thing I've ever done, and I thought Christendom was really, really hard, but nursing school is just like a whole different ball game. I thought when I went through, I thought I got through Christendom, and Christendom was tough, and I, wrote really long papers and did loads of studying, and I've learned great study skills, but nursing school is very different. You still have to memorize and learn, but it's a lot of critical thinking and understanding how the professors are thinking, and it's like a different way of approaching exams. The exams are all multiple choice, which sounds like it could be easy, but you have 20 questions on your exam. If you get 4 wrong, you could fail the exam. So they're really tough. There's one nursing meme that everybody loves to show, and the question, they say this is like a question on a nursing exam, and the question is, your house is on fire, what do you do first? And the options are stop the fire, extinguish the fire, put out the fire, and some other way of putting out the fire, and you try to pick which one's right, and they say, no, you're wrong, it was really stop the fire, and they're all the same. So that's how nursing school seems, that's how the exams seem. So it's really like a big adjustment on how to answer those kinds of questions. It's just good to kind of be prepared for shifting from Christendom type studying to nursing school type studying. It's really challenging. Yeah. But it was, all the nursing schools are kind of the same, and if you just persevere, you stick with it. A lot of people fail out of nursing school. It's really easy to fail nursing class. I just want to be honest with everybody. I almost failed multiple classes, and I did great here at Christendom. I didn't have a problem. So nursing school is tough. But if you do fail, like a lot of people do, don't get discouraged. You just pick up and you take the class again the next semester or the next time it's offered, and you continue on. And don't I was just shocked when I got into nursing school and almost failed something, and I thought, whoa, maybe I can't be a nurse, I'm not thinking right, but that's just kind of part of the process in school, and just don't give up, just keep at it, keep plowing ahead, just get back in the race again, and you'll get through and it'll be fine. So.
Okay.
All right, so Emily, tell us how physical therapy school is different.
Yeah, so I guess starting where they started at prereqs, so I guess my mindset, once I discovered halfway through Christendom that I might want to do PT, I didn't really want, I mean, when you have a class like short stories with Mrs. Hickson or like outlaws with Dr. Reinhardt, like of course you're gonna want to take those because they're unique to Christendom. So I didn't really try and do prereqs here at Christendom, and I don't really know that I knew what they were. I'm sure there's more now, and I might have a different look on it if I went to Christendom now, but I just started doing at-home summers. I would do, I think the first summer I did psych, and I did biology, and then there's also stats, there's chemistry, there's physics, there's anatomy phys. We didn't have any like more advanced microbiology or anything, so it was pretty straightforward. There weren't a ton of them. And like I said, I think I had like 2 or 3 summers worth of like an intense 5-week course where you have like 3 days a week for like all day. But I mean, it was worth it for me to do what I wanted to do. And then that, again, I had to take a gap year, but it was fine because I was working and I was getting more experience, and I was then applying to PT schools, and I just had a lot more freedom to, kind of figure out what the track was and really focus on, especially the anatomy phys. So our community college in Charlottesville was they had a lot of healthcare professionals that were like pre-healthcare professions. They had nursing and everything as well. So their anatomy phys was really, really well done. I thought the teacher was like explained things really well with kind of the lens of you're all going to probably do healthcare of some kind. We had a cadaver lab, so we got hands-on experience already. So I was again really pleased. Unfortunately, towards the tail end of that was COVID, so it turned online and they didn't really know what they were doing with that, but it was only like a month, so we just sort of finished up there. So then I started PT school in 2020. And so physical therapy is a doctoral entry-level degree. It used to be a bachelor's degree back in the day. Then it switched to being you had to be a master's. So my mom got a master's back in the 90s. But they've transitioned now, so everybody who wants to become a PT now is going to get a doctor of physical therapy. It's a 3-year program. And so again, I started in 2020, and it is, again, like Rose was saying, it's very intense. I think it's also just different from Christendom because, when I had a background in English, you read this book, you basically know it, and you can kind of, not that you can make it up, but you can kind of have a little bit more freedom to elaborate and fluff up your essays and kind of just, get through it. But if you don't know where the, bicep attachment is, you don't know where it is. It's a lot more, again, hard facts in that way. And we also did have a lot of hands-on practicals, so I would have to, treat, either a professor or a classmate of mine. I would have to go through a practice exam with them and have my teacher just sitting there staring at me and watching me do it. And that's a little bit stressful, but again, we made it through. And they teach you all kinds of different things in the hopes that when you graduate, you are a generalist. You can go into any setting of physical therapy, whether it's pediatrics, geriatrics, hospital, outpatient sports, really anything that you want to do, you can do. You can get additional certifications past that, which I, again, have been a PT for 6 months, so don't have any of those. And I really don't think that it's essential. It's more just kind of if you really know, hey, I love neuro and I want to treat only stroke patients and spinal cord injuries, and that's just, I want to learn everything I can about that, then you can get additional certifications that look great if you're trying to start your own business, or probably come with a little bit of a pay grade and just kind of some extra letters after your name, but just kind of ways to further your education and specialize. But at the moment, I see a wide variety of patients, and PT school prepared me for that. What I liked about Shenandoah is that we had 3 part-time clinicals, which was 1 day a week for 10 weeks throughout a semester, including starting the very second semester we were there. We were getting experience just following a PT and saying, what do you do? And just watching them do it and asking lots of questions. And then gradually, as you go further in the program, you're doing more. They're saying, hey, you learned that skill, like practice this joint mobilization, or like do this with the patient, and like this guy is your patient because he's pretty simple, and you kind of get that hands-on experience. And so after our 3 part-times, we also had 3 full-times, so an 8-week, a 12-week, and then another 12-week. So some schools you kind of have to look at, some of them just do 2 whole years of didactic in the classroom and then like 2 16-week clinicals, and that's it. But since there's so many different settings that you could work in, you know, if you only did a hospital and a sports, but then you decide maybe I want to do kids, but you've never had that experience, it is pretty different, and you really need some hands-on experience so that you're not just completely, you know, at a loss when you're trying to start your job. So I really liked having a chance to kind of see a bunch of different clinics. And then they also did bring in patients from the community to Shenandoah, and we had small groups that we were treating adult neuro patients and pediatric patients. So we really had a lot of hands-on with patients. And I think that was kind of one of the strengths of that program, and what I think again was really helpful from Christendom, just being able to have that interaction, that communication. They were one of the schools that did interviews. Some schools didn't interview, and that was kind of a red flag for me when I was looking, because I'm like, if you don't want to meet me and see if like I can hold a conversation and see if I'm personable, you know, that's so important in healthcare. And I've seen healthcare providers who are so smart but have no bedside manner, no personable nature. And I think that, you know, it's really the most important thing is just knowing how to, again, have that empathy. And you'll learn, you know, I definitely had classmates who had to retake a semester, or even, you know, do PT school in 4 years instead of 3 because they completely, you know, couldn't do a class, and they just kept at it, and they got it, and they made it in their profession. So you'll learn the science, you'll learn all of the things. It is tough, but if you know, are a decent human being and you know how to relate to people, I mean, I think, and I've already heard from patients, like personally, that is like one of the most important things. So that's kind of my experience with that.
Yeah. So I feel like we could continue talking about schooling just for the rest of the time. So if you all have other questions at the end, you can hang out, chat with them, ask them maybe specific questions about schooling, but also if you all would be available for them to contact you at some point, that would be great.
Yeah.
And I might even talk to you all because I'm talking to the students about these things and trying to answer some of these questions. So this has been really great for me. So
Can I jump in and say one other thing about the same thing
about schooling? Yeah.
as Emily was saying about the clinical hours? If you can find a program that has more clinical hours, like definitely go with that. You learn so much in your clinical time. Like you definitely learn in the classroom, but the clinical time is where you're interacting with the patients and you're really seeing how the real nursing world works. And some programs have like a requirement for more hours than others. I think that the accelerated BSN programs, they do more class time hours and less clinical hours. The community colleges, they tend to err more on the side of doing more clinical hours. So that just really, like, if you can get loads and loads of clinical time, I wish the nursing schools would have even like double the amount of clinical time they have. You could really like go, like there's so much more that you could learn. So just look for that when you're looking for a program, look for one that has a lot of clinical hours, and that's gonna really get you off to a good start.
Thank you, that's very helpful. All right, let's switch over to what does your day-to-day kind of look like, because it is probably very different for all 3 of you. And if you can, share some stories as well, because they love to hear stories about what it's actually like to be, you know, tell us about a patient you've worked with, but give us the rundown of what day-to-day is like, Rose.
Okay. Well, let's see, for nursing, so if you work in a hospital, you can work other places than hospital, but I've just worked in hospitals, so I'll give you a sense of what that's like. In the hospital, you can work in 3 different levels of care. So there's the ICU, those are the sickest patients. The nurses usually have 1 to 3 patients in the ICU that they're responsible for. The next step down would be step down, literally. It's just a little below ICU. They're not so sick that they need to be on a ventilator or they need to have sedating medication. So they're doing a little bit better, but they're still pretty sick. And then below that would be med-surg. Those patients are doing a lot better. They still have a lot of like medical issues that we're managing, but they're more stable. So I've worked in step downs mostly. It's a really nice blend between the two because you get patients who are sick and they really have a lot going on. You really can learn a lot, but if they get more sick, you can send them to the ICU and hopefully they can treat them there and they can get better. But so it's a nice like middle point to work in. Nursing shifts are 12 hours long, so there's either day shift or night shift, so either 7 a.m. to 7 p.m. or 7 p.m. to 7 a.m. would be night shift. For day shift, you have to get there a little bit early. There's usually like a little huddle meeting at the beginning of the day, so you have to get there by 6:45. You get your assignment, like you need a few minutes to get everything set up. So 6:45, that means, depending on where the hospital is, like I leave at 6 in the morning, means I get up at like 5:30 or 5:15. So it's a really like early morning. And then you don't finish, your shift finishes at 7, but you need to do your shift handoff report and just tie up some charting things. So I usually don't leave till 8. So, and then I get home by like 8:45. So it's a long day, like 5:30 to get up till 8:45 at night. So it's a really long day. So it like takes stamina. But anyway, so you get there, you get started, you get a nurse handoff report from another nurse. The nurse who is on night shift will give you a report and tell you everything that's going on with the patient, what went on during the night, and just kind of any like plans for the day. Then I go around and check on all my patients, just kind of see if anyone's having any like immediate issues that need to be addressed. By this point, it's like 7:45 or 8 in the morning. Any like if patient's having a new pain or shortness of breath or something's going wrong with their wound drain, like I try to address that in the morning so that it doesn't become an issue as we go throughout the day. Everyone has a round of medications in the morning. It's unbelievable the amount of medications patients are on. So most people have like 10 to 20 meds that they take every morning. So we have to make sure they get those on time. We get everyone's vital signs, make sure that those are stable, don't need anything to be fixed. And then in the meantime, you're kind of addressing issues that have come up. So like somebody all of a sudden, he was there for, like knee replacement. Now he's reporting that he has shortness of breath, he can't breathe, he doesn't feel good. So you have to kind of stop what you're doing, stop your medication pass, and then you go check on the patient, see what's wrong. Maybe he has, the nurses are the eyes and ears for the doctors and the other staff, so it's really important, like your assessment when a patient's having an issue. You have to go in and assess them, kind of figure out what's wrong, and then report it to somebody else. So this is just kind of a common scenario, so I'll just sort of run through how it goes. So he says he has shortness of breath. That's new for him. It's not related to why he was there in the hospital already. So I'll do like further assessment and listen to his lung sounds, try to determine like, is this shortness of breath due to like fluid building up in his lungs, or is it due to some sort of constriction of the airway? You can tell all that just from the way the different lungs sound. You look at his other vital signs. Is anything else unstable? Maybe his heart rate's actually really high now too. Maybe he has a temperature. Maybe his blood pressure is low. And right away you can tell all these are signs of some sort of infection. So he's probably developed some sort of infection in his lungs, probably pneumonia, which is really easy to pick up in the hospital. You report all those findings to the doctor. The doctor will usually order a test, like a chest x-ray, see what's wrong. Then he'll order an antibiotic. He'll order blood work. You have to then get all that started. You have to do the blood work. You have to hang the meds. You have to, just continue, encourage the patient, like make sure he doesn't get worse. Monitor his oxygen level, put him on oxygen if he needs it. If his oxygen starts to get worse, you might have to call the respiratory therapist. They can come in. There's a lot of like extra resources in the hospital, so the respiratory therapist can come in and help you manage like what's going on with the patient. If he's having secretions, maybe he needs suction to help him like clear out the secretions from his throat so that he can breathe better. And then you just continue to monitor, make sure the patient's not getting worse. If he starts getting worse, his breathing really deteriorates, he might have to get sent to the ICU. And so in the meantime, how long does that take? That takes like an hour or two to do all that, and all your other patients, like your 5 other patients, are just waiting for their medications, or they have their own issues. So that's kind of like the things that you get into in a nursing, like the beginning of your nursing shift, there's always issues that come up that you have to be addressing. And again, like I said, it's really important. The nurses are like the main ones who see the patient all day long. Other people come in, the doctors come in, but they see the patient for 20 minutes and then they leave again. Other healthcare providers come in, see the patient, but they're not there the whole day. So nursing is really important to like pick up on little things and then report them to the appropriate person, and really prevent things from becoming an issue, stop things sooner before they become an issue. The rest of the day is kind of, again, more meds, like managing people's symptoms, admitting new patients. You'll get new patients in, then you have to do all their admission paperwork. You have to, figure out what's wrong, like let the doctors know, make sure orders get in, and then you have to discharge patients. So patients, you have to do all their discharge education, like make sure that they understand how to take care of whatever they're going home with, make sure they have appointments set up. And then what else? We do a lot of like IVs, putting IVs in, wound, like dressing changes, managing different drains. And a lot of that depends on what kind of unit you work on. So like if you work on, I don't know, just like a cardiac unit, you're going to be doing a lot more of monitoring the heart. If you work on a surgery, like a ortho surgery unit, you're going to do a lot more of maybe wound drains or dressing changes and making sure people are getting up out of bed, make sure they don't develop blood clots. So there's kind of different focuses depending on the unit that you work in, but that's sort of a kind of a general rundown. And then you get to the end of your shift again. By this point, you've been running nonstop, you haven't sat down all day. And you have to chart a lot. There's tons of computer charting in nursing, tons, in all of the healthcare field now. There's so much charting that has to be done, and that takes a long time. It's great, it's on the computer because everyone can see it, and it's like, across the board it's very clear, but it's just a lot of charting you have to do. And if you don't get to that in the middle of your shift, you do it after your shift is over. So maybe you get to the end of your shift, you give your handoff report to the nurse who's there for night shift, and then by that point it's 7:45 and you have to stay another half an hour, make sure you charted everything that you did with your patient. If it's not charted, it's considered not done in the hospital, so you have to make sure that everything that you did is in there, like all the phone calls you made, make sure that everything's, there's a paper record for it so that if any problems come up later, you can prove that this is the care that you gave to the patient. So it's a long day, and I wasn't ready for that when I got into nursing. I remember my first 12-hour shift I was still in nursing school, and I was like absolutely dead by the end of it. I could like barely walk home. I was so tired. So it's long, and you you develop stamina as you go along to get through it. You make sure that you eat well, you take your breaks. It's hard to fit breaks into a day like that because it's just you're allowed a half-hour lunch break, but you take your lunch break when you can get a minute. So it's not like, okay, at 1 o'clock everyone goes on their lunch break. You just try to fit in your lunch break when you have a free little chunk of time. But that's really important to do. And so none of that is to scare anyone away from nursing, just to kind of give you a realistic idea of what like the daily day, the day is like for nurses. And it's great. I really love it, but it's a lot of work. It's tough. So.
Okay, thanks. So Emily, how many days a week do you work?
Yes, right. So we work 12-hour shifts, 3 12s a week. So that's 36 hours a week for full time. That sounds really nice on paper. It means you have 4 days off. Like, so everyone, like, who else wouldn't want like 4 days off, like Friday, Saturday, Sunday, Monday? But it doesn't quite work out to be like as great as it sounds. It's still really, really good. But you usually have to work every other weekend. And weekend means Saturday and Sunday. And then you work, your other 2 days during the week. So maybe you work like a Monday, a Tuesday, and a Friday. And then you work, maybe you have the weekend off, and then you work like a Monday, and then a Thursday and a Friday, and a Sunday. So you could work 3 or 4 days in a row, potentially. So, and then you have to work so many holidays throughout the year. That's the requirement in the hospital. So it's a lot of like long days. And again, I just wasn't something I was aware of going into nursing. I didn't realize, I thought, wow, 312s and you have 4 days off? That sounds amazing. So it is good, and you can structure your time to, make that, like you can have 3 or 4 days off in a row, but that means that you probably have to work 3 or 4 days in a row, and that's tough. To work 3 12-hour days where you don't get home until 9 p.m., and then you have to get up and go, get up again at 5:30 the next morning is really long. So they're just long days, but it's still good.
We appreciate you and that hard work, for sure. So Emily, tell us how your days are different.
Yeah, and so I kind of knew that structure going into it, and I decided that was not for me. You never have to get people up in the middle of the night to do PT. Just doesn't happen, so you're never going to have to work night shift. You can work, you can kind of have a little flexibility if you want to work 4 10s, or I work 5 days a week for 8 hours. So I just have kind of a normal schedule. I leave, my first patient shows up at 8, so I can't show up at 8. I have to show up a little bit before, just about 7:45, if I know that, I can do a quick chart review if I've seen them before. So in the outpatient setting, they're all scheduled. It's kind of like your doctor's office. So I have my whole schedule of patients for the day, and now some of them will cancel if something comes up, and the front office or I will be calling other people to try to get them in if they were on a wait list or if they just needed a second appointment. So it definitely has more of that structure of daily patients. So I will have probably about 7 or 8 patients a day, and now that's like considered really good for PT. So there's some clinics that are more kind of cash-based, private outpatient clinics who will do like 15 patients a day. You only see them for like half an hour, kind of in and out, and they're trying to see as many as possible, or they'll see 2 at once. And that was also something I did not want to do. So I only ever see one-on-one. Typically, if it's a new evaluation, so hey, I hurt my knee and I need to go to PT. So the first one is going to be an evaluation. It'll show up on my schedule as a 60-minute block, so I have a whole hour to just kind of see. So today I had a lady who had actually been in PT in like January for her ankle because the car door, I think, had like blown with the wind and like sliced her foot open. So they were working on ankle stuff. But then, as she was going along, she was getting these new dizziness symptoms, and they did an MRI, and it turned out she had a cerebellar hemorrhage. So she had a new medical condition. That means that when she comes back in, and after she had already been in the hospital and came back in for more, not just foot stuff, but now she had all these new deficits, we have to do a new eval so that we can figure out, okay, so now where are we starting? Did you, used to not walk with a cane and now you need one? Or, now you have these new coordination and balance things that we need to work on, these new weaknesses from it affecting your body. So that first eval is really about kind of the structure of an eval would be you sit down and you just talk for the first 20 to 30 minutes. What's going on? How long has this been going on? What are your symptoms that you're having? Be really descriptive and trying to get, you learn in PT school kind of what kind of questions to ask to figure out. Well, sometimes it's straightforward, like, okay, they had a knee replacement, and now they're here, so it's not like you need to figure it out. But other times it'll be like, oh, wow, like my shoulder keeps clicking when I do this, and then like you have to do all these special tests and try and figure out, is it their labrum, is it their biceps, kind of what that is, if they're appropriate to be seen by PT. Sometimes people will be like, I have back pain, but they're having, an aneurysm, like an aortic aneurysm. There's sometimes these medical conditions that aren't actually PT appropriate, so you have to know all the big scary things that you can recognize and refer, because you do. So in Virginia and in a lot of states now, you can go to a PT without a doctor's note, called direct access. So that's been a huge recent development. You can also get, a lot of times people will get a referral from their doctor to go to PT, but if they're coming in off the street and they're about to stroke out in your clinic, you need to be able to recognize that. So even though it's kind of an outpatient, that is, they come in to you, outpatient means like they don't stay there, you're in the clinic and they come in, even though it's that kind of setting, especially in the setting that I work in, which is a hospital-based outpatient clinic, you gotta be able to know when they're not appropriate and they need to be referred. So anyway, that's kind of how the eval runs. You do the subjective part, you listen to them, then you do the objective, you do their tests, and then you kind of wrap it up for them, say, hey, here's what I think's going on. You schedule, a lot of times the front office helps schedule a bunch of follow-up visits. Typically we see people about twice a week just in our clinic. That's about how many we can get in, and then for about 6 to 8 weeks. And then at that time we say, are you making progress? Do you need to be recertified for more visits? Or do we feel like you're ready to be discharged? So it's kind of that's about like what a course of care looks like. So in my any given day, I'll have some evals. That's a lot more paperwork, so hopefully not too many of them, because you have to then, go through all the things, write goals for them that are achievable and functional, related to things that they can't do. That are, you're not going to write them ridiculous goals that they're not going to be able to achieve, because you're trying to find things that are, they'll be able to prove to insurance and prove to themselves, because a lot of times they don't see their own progress. So, the evaluations and then follow-up visits, typically 45 minutes in our clinic is just what we tend to do. So I've got all my different patients that I'm seeing every once in a while. So like when my patients cancel, we do have a productivity standard where we are kind of being looked at to see how many patients we're seeing a day, how many units we're billing. So whether they're doing manual therapy, exercise, balance training, there's like different categories of things that we will do, and so they want to make sure that we're not just twiddling our fingers with no patients. So I fill my time. Like today, I had a big gap. I'm getting certified in a mode of Parkinson's rehab. So for Parkinson's disease, it's a way of kind of helping people move bigger, because your movements get very small and you're at risk for falling, and just everything becomes really small. You have a hard time starting and stopping movement. So getting them to move bigger. So I'm doing this online class that I'll fill my time with. I do have a lunch break that has some documentation time built in, but other than that, there's not a ton of documentation time. So you do, unfortunately, kind of have to be good at, and you'll get practice with this in clinicals, but type in while you're doing things. If you're having them do 10 heel raises, then 10 bicep, whatever you're doing, you're trying to write down the objective things that you do, again, to have that paper trail in case something comes back that they need to see what you've done. I'm not going to remember later if we used 20 pounds or 25 pounds unless I write it down in that moment. So I'm kind of just trying to get a sense of, and then every treatment visit, I'm doing what's called a SOAP note. So it's got a subjective, which they said, last time I was so sore after PT, so I'll write that down, go, okay, maybe let's not go that hard this time. You really want to, pay attention to what they're saying. And then the objective is how many reps and sets of things that you did. And then the assessment and your plan is kind of, hey, this is my clinical reasoning. I think that they are really progressing well. Like they were able to tolerate more weight today. Their strength is improving because they had an extra. They didn't have to use upper body support this time when they were doing this. Kind of like talk about what your findings are and then what your plan is. Which is also really helpful if you're not the one seeing the patient next. We try and have the same patients on our schedule, but a lot of times, especially in our clinic, we have lots of different PTs, and if they got to get an appointment and you don't have an opening, somebody else might see them after you. So that's another big reason why you want to have clear and consistent documentation so they know exactly what you did, how the patient responded, and what your plan is or what you think they need to work on next. And then we also do communicate a lot with other people, so I'll send them a message like, hey, this guy looked like he had a really tough time with you. Like we'll just kind of chat in the office or send each other messages to make sure we're on the same page. But that's definitely a big element of it that I feel like I've always had a strong suit with documentation, because it's writing, it's expressing yourself clearly using the right number of words, not too many, but not too few, so that they know what you did and you can follow behind. So that's kind of how my day's set up. Now, just really briefly, also over in the hospital, because I do go cover over there, we have to do one weekend about every 2 months or so. rotating through, because that way the two inpatient therapists who are over there full time don't have to do every weekend as well. So we kind of go over there and cover, and I love that as well, because you're doing your evals, you're doing your follow-ups, but it is a lot quicker, it's a lot more functional. It's not, let's figure out exactly what's going on with your shoulder and doing these like really creative return to sport things. You know, like if you're a soccer player, you might be playing soccer in the clinic with your passing it back and forth and watching them do some jogging and stuff and really getting, you know, specific to what they need to do. In the hospital, it's, you know, how much assistance do they need basically with all things mobility? So can they roll over in bed by themselves, or how much assistance do they need? Can they sit up? You know, can they stand up? Do they need an assistive device like a walker? Did they not use one before and now we need to order one for them so they're safe to go home? And it's basically all comes down to just where are they going to go after the hospital? Because, you know, you could have a really healthy person out on the street, you know, whether they're an older lady who's now all of a sudden fallen and broken a hip, or, you know, somebody that's had a heart attack and they're just completely different than when they came in. They might not be safe to go home with what's their setup at home. They might not have anyone there with them, and they can't do stairs, and they have to do 13 stairs to get in, and they're just not going to be able to do it. So it's our job to say, okay, hey, they walked 20 feet, so they can go to the bathroom and back, and I think that they're safe to do that by themselves, but they have this, you know, barrier to their discharge, so we can decide whether they're most appropriate for a skilled nursing facility or inpatient rehab, like I was talking about, which is more intensive therapy, or long-term care sometimes, even if they're just not going to make any progress. They were bedbound at baseline, you know, just kind of getting a sense, like, and making a clinical decision. This is how they're doing, and again, communicating with the nurses. Hey, I just got him up and walked, and he did great, and you know, that way that's helpful information for them to know. So that they can go up to the bathroom and they don't have to use a catheter unnecessarily. You know, we always want to encourage motion, because the earlier you move, the less complications you're going to have. So it all comes down again to just kind of getting them up, getting them moving. I've gotten a lot of, you know, very sketched out looks when people are like, we're going to do what? I just had hip surgery. It's like, yes, and we're going to move, and it's going to be okay, and we'll get through it. We'll just see what you can do. So it's a lot of, you know, again, can you imagine walking into the room and having no bedside manner and being like, let's go? You know, they're not going to look nicely at you, but if you explain why we're doing it and you kind of take a moment to just ease their fears, you got a lot more success when you're trying to get anybody up. So here at the hospital, I think there's only a critical care step-down unit, and then there's also a med-surg unit. So there's not the intensive ICU setting, but PTs are totally there in those bigger hospitals. They're in the ICU, getting people up, walking, even if they're on trachs, ventilators, ECMO, where your blood is literally getting pumped for you. Like, got to get motion early on. So there's some really, really neat settings where PTs will be just with those really basic functional, let's get you up, get you moving, work on safety, and work on discharge planning. So that's kind of some of the things. I mean, of course, every setting has got its own little things, but those are sort of my daily things that I would do.
Wow, that's a lot.
Yeah. Can I jump in quickly and say one other thing? The nurses love the physical therapists. They do so much to help, because they come around every day pretty much and get all the patients up. And the nurses can get them up out of bed too, but sometimes we're so busy that we don't have the time to go into each patient. It might take like 20 minutes to get them up and moving into the chair, so we don't always have the time to do that. So the therapists come around and they do so much with the patient. They'll even get them cleaned up or walk them to the bathroom. Or
you don't get out of that. If they have an accident, you're helping.
Yeah, so they're amazing. So we love it when they come around, and you know, once you get the patient out of bed, it does so much for them, just getting like better overall. So we're so glad when the therapists come around. And even the doctors, they rely on the physical therapists to, like you were saying, to tell them where the patient needs to go. So the doctor will write the discharge order, but he'll say, depending on what physical therapy says, this patient can go home, or it can go to rehab, or it can go to a nursing home. So like they make a lot of big decisions for the patient. So it's really like an important job.
Yeah.
Oh, thanks.
Yeah.
All right, so Olivia, tell us a little bit about your day-to-day, and then we'll we'll
Yeah.
round out and have the students ask you all some questions.
Yeah, absolutely. I thought with family medicine, at least in residency, every month I'm doing a different rotation in all kind of the major areas of medicine. So I'd give you a quick rundown of a couple different things. Probably the hardest rotation that I do as a family medicine resident is the inpatient medicine rotation, and that's where we are in the hospital taking care of patients on the general medical floor. So a typical day, you get to the hospital a little bit before 7 o'clock. For me as a second year, I'd be assigned somewhere between 7 to 9 patients on the floor. From 7 until 9:30 in the morning, I have to see each of those patients. I ask them how they're doing, check on them if there's any changes from the night before. I do a physical exam, listen to their heart and lungs, check out if they have a stomach complaint, kind of go more into that, do an abdominal exam, do a full exam. I look at their labs from the day before. I check on any medication changes or if there were any events overnight. And then I do that for all the patients. At 9:30, we gather together in what we call rounds. So that's where my attending physician, who's kind of like the overseeing physician for the floor, we get together with the attending, the residents, pharmacy, the nurses, especially the nursing supervisors present. And sometimes we'll have people like physical therapy pop in. We have social work also present during these rounds, super helpful. And that's where we talk about each of the patients on the floor. And we give a kind of quick version, a quick summary of what's going on with this patient and what the plan is for the day. So that's where we hear, PT, physical therapy, PT, saw this patient, they cleared them, they can go to a nursing home. And then we ask the charge nurse, okay, any other events overnight that we're missing? And then I, as a resident, will come up with a plan for the day. Okay, this patient was clear to go to the nursing home. We'll plan to contact their family, just make sure everything's all set, and we're going to get them ready to discharge. Or they have to stay another day. We need to start antibiotics. They have a new pneumonia. We kind of make decisions at that point if we're going to change any medications, if we're going to order any tests, imaging, x-rays, whatever. And the big question is, are we going to discharge them or keep them for another day, and how can we justify either one? Then after rounds, that typically lasts for about an hour or so, I can update the patients. I go to my 7 to 9 patients again, tell them the plan for the day. At that point, I will give their families a call if that's warranted, if they need to let somebody else know, especially with older patients. Sometimes they want you to let their child know, their son, their daughter, whoever needs to come pick them up. Sometimes we also have to do family meetings if there's like an end of life conversation that we need to have, if there's a goals of care conversation, how aggressive do you want to be in treating a certain condition, or what are your wishes, I guess, in treatment or whatever it is. So we'll have those meetings a little bit later on in the afternoon. We also, as residents, will take admissions from the emergency room. So that's patients coming into the emergency room. They are deemed too sick to go home, so we admit them to the hospital. And that means we go to the emergency room, we talk to the patient, we take a history, and we do a physical exam. And then we say, okay, we're going to admit you to the hospital, and we put all the orders in. So that means transferring, the order to transfer them up onto a medical floor. We put in all of their medications that they need. Order any additional testing, imaging, and we order labs either for later that day or the next morning. And then we spend the rest of the afternoon kind of going between trying to catch up on all of your documentation like they've been talking about, trying to finish up your notes. You're continuing to check on your patients. A lot of time they'll have questions, so you're paged by the nursing supervisor. Hey, 301B wants to talk to you. They have some questions, so you run up there, you go talk to them. Hopefully at some point you get some lunch, and you're checking on your nursing home patient that's supposed to go to the nursing home. The biggest thing, I'm sure you two know this too, everybody's always waiting for someone to have a bowel movement before they can leave. So you're like, all right, did the patient poop yet? Can they go? No. All right, what do we do about that? Then you're working between admissions, between any pages you have. That goes on until 7 p.m. We do a handoff to the night team who are taking care, basically that's, if any patients are very critical, if you're worried about them, you'll give them a heads up, hey, 301B wasn't doing so well, I've done this, this, and this, you might want to keep an eye on them overnight. I usually spend another hour to 2 hours finishing up documentation after that. You can either stay at the hospital, go home, but usually, yeah, another 2 hours or so, I'm doing work outside of just the actual work of the day. Then that's my free time. I can come home, eat dinner, do whatever I want to do for the day, and then go to bed somewhere between 11 to midnight, hopefully earlier, and then start all over again. And those rotations, you are working typically 5 days a week. For our residency program, we also cover one weekend each month. Then compare that to, currently I'm on an ear, nose, and throat rotation, which is super chill. I went to the clinic, so this is an outpatient setting, like you're in an office setting, and I was able to, what did we do today? I put a scope in someone's nose to look at their throat, and we were able to do some biopsies. Someone had like a little lesion on their ear. Weren't sure what that was, so we did a biopsy to check, is this cancer, is this just abnormal cartilage? I will tell you though, for this rotation, even though you get out pretty early and you get a full lunchtime and everything, my downfall is, not to be gross, earwax. I cannot handle it. I can handle blood, I can handle vomit, I can handle pretty much everything else. I should have probably realized there would be earwax removal on this rotation, so I do a lot of deep breaths. I've been very proud of myself. I kept it together. Whew. But yeah, it's been a tough one. But you get out early, and then I will say the last thing I'll quickly run through is we have an outpatient clinic. So this is where patients from the community come, like a doctor's office setting, and in a typical day, I will have anywhere from 8 to maybe 12 patients scattered throughout the day. Again, you have a set lunchtime at noon, noon to 1. And in the morning, you will just be seeing patients that say, hey, I'm coming in and I feel sick, or I have a 3-month follow-up. I have diabetes, I need to adjust my insulin regimen. So we spend between 15 to 30 minutes for most patients discussing what's been going on since the last time I saw you, making any changes. If it's a new patient, we spend about an hour with them, getting a history. We're doing physical exams, deciding, what's the best course of treatment. We make referrals to specialists at that time. And those days are actually pretty good. You end around maybe 4 or 5 p.m. And you have the rest of your night to do whatever you need to do. We do have some didactics that are required, so that's like classes that we take to help us get ready for our board exams when they come up. But yeah, that's kind of various days in the life there.
Sure, thank you. Okay, that was so informative. I don't know about you all, but I learned a whole lot. So thank you all for sharing that. I can't believe we've already talked for over an hour, so I want to be mindful of everybody's time, because I have so many more questions for you all, but I want to give you all a chance to ask, what do you really want to know from them before we leave here? So if you've got a question, raise your hand, and Gabrielle has a microphone, so wait until she gets up here. Yeah, come on up, Gabrielle, right up here. Raise your hand again. She didn't see you.
Okay, I was wondering, you had all mentioned at some point, or most of you, something like, oh, maybe you are just looking at extra letters at the end of your name with the BSN, maybe it opens up to more experiences. So what are things that hospitals are looking for right now that make hiring process easier, or further studies easier? And what would you recommend coming out of Christendom?
Well, mine's easy, because you have to have a doctor of physical therapy. That's where you start. Everybody starts there if you want to be a PT. And at this point, I really don't think that, maybe if there's a lot of competitive applicants, if you have an extra certification in orthopedic manual skills, and that's what the clinic is really focused on, you might have just a resume builder. But you really can, it's true, you really can do anything with just your general degree. I know so many people who are amazing PTs, and they haven't really felt the need to get any other certifications. That may change. They're also starting to do some residencies where it's more similar to medical school, where you're, again, you already are a PT, but you're doing more schooling, more certifications, and more mentorship. But you just have to be aware in your first job of where has good mentorship, because you're going to have questions. I would not recommend home health PT for your first job, because it's just you go into people's houses and if you have a question or if they start deteriorating and you don't know what to do, then you don't have that person with you. So, I'm kind of in a good clinic where, everybody, PTs are really sought after right now. That's just how it is. They are happy to hire new grads. You don't have to, worry about what certifications or extra you're going to get. That's more just you have to get a certain number of continuing ed hours to keep your license up and renew it every 2 years. But if you want to do more on top of that, that's more just to help you be a better clinician. And it is kind of a lifelong learning thing. So I guess there's probably more specific things with nursing, because I know there's a ton of different letters and confusing things with that. So maybe you can speak to that.
I would definitely recommend a BSN if you can. Just get it out of the way at the beginning, especially if there is like a 1-year program you could do after Christendom. It's not absolutely necessary, but it does like just create more opportunities for you in the future, and if you can get it behind you, it's great. I had just gotten a diploma, which is kind of like an associate's, and then I did an online BSN program. It took me like another year. So you can do it that way too, but it's kind of nice to just knock it all out at the beginning if possible. Same thing, as Emily said, the hospitals are short-staffed all over the country for nurses. So you will absolutely be assured of a job once you get, once you pass the NCLEX. That's one of the great things about nursing and a lot of these healthcare fields is that you're always like assured of a job. And even right here in Front Royal, there's like 5 hospitals within like a 45-minute drive. So you could work at any one of them. Anywhere you go, even if you're out in some rural area, there's going to be a hospital there that needs nurses. So I wouldn't worry too much like about the hiring process. Once you pass the NCLEX and you're an RN, whether it's an associate's or a bachelor's, you can get hired. Yeah.
Excellent. Olivia, did you have anything to add to that?
I'm so sorry, I couldn't hear the question.
Okay. You're good. Okay. We'll move on to another question. Yes. Who else has a question for our wonderful guests here? Alex?
I know you mentioned this, Miss Stevens, at the start, but what is exactly traveling nursing?
Oh, yeah.
Oh.
We didn't go there.
Travel nursing is really fun. It's so I always love to travel, just in general. Traveling's my hobby, I say. And so with travel nursing, you take, there are hospitals around the country that are, maybe they're short-staffed and they're working on hiring someone permanent, but they haven't gotten them in yet. They have like several spots they need to fill really quickly. Maybe someone just left and they need to fill it quickly. So they will hire a travel nurse. So travel nurses take assignments. They're usually 3 months long, and that can be anywhere in the country. So you go through a travel nursing agency and they look up hospitals all over the country. You could say, I want to move to Phoenix, I want to live in Phoenix for 3 months, and they'll find you a hospital there that needs nurses. The travel nurses actually get paid a lot higher because they're coming in as like staff to help out and fill in a slot for a while. I was going to say that they don't get benefits, but agencies actually do offer them benefits, so you still get benefits, and you still get to travel. They give you a stipend for housing, stipend for travel expenses. What they do is they keep your hourly rate really low, so you'll get paid like $20 an hour for your hourly rate, but then they'll give you lots of extra bonuses that actually bump like your average hourly pay up to like 50 or 70 an hour. So it's like a really nice way to get to travel around the country, see like lots of different hospitals, learn how different hospitals do things, and have fun traveling and living in new cities at the same time. I did it for 2 years, and I loved it. It was really fun. I worked in different cities like along the coast that I could live near the beach. So my last one, I was down in Fort Lauderdale, and I lived a block from the beach, and I had a pool, and I just spent all my days off just in the sun. It was amazing. So, but you're on the go a lot, and like just as you're kind of getting comfortable with the new job, you have to get up and go to a new one. So you have to be able, and they don't give you much like orientation time. So it's something that you get into after you've done nursing for a couple of years, and you can jump in pretty quickly without much training. But after a few years, if you can do it, I totally recommend it. It was a lot of fun.
And I will say there's also travel PT. So in my clinic, there's several travel PTs. Again, it's like a 3-month. And when you're desperate for PTs and somebody leaves, then you hire a traveler and they have to pay them more because, you know, again, you only have that little bit of orientation and it's hard to move that quickly. But if you're in that season of life, it can be a really fun opportunity. And I do know some people who did it right after graduation, and more power to them. But I had babies during PT school, so I was not about that life. I really like my stability, and I was purposely seeking out clinicals in Front Royal and in the area so that I could network and get my job secured after graduation. So there's definitely travel PT if that's your boat. And if you also want to get married and have a family, PT is a great flexible career that can allow you to do that too. So if you have more questions about that, I'm happy to answer that, because all my classmates thought I was crazy, but we had a summer off, so I had a baby and just kept going, and they think that I'm crazy, but that's the Catholic way.
That's awesome. All right, what else? Who else has got a question? I know I've talked to several of you about being interested in healthcare. Yes, up here.
So I kind of have like two questions. So they're kind of similar though. So I'm a freshman and I'm looking into going into like being a nurse, possibly in pediatrics. And I was just wondering, I want to use my summers to my advantage. So what would you recommend doing over the summers? So like I've looked into like getting trained as a CNA or a PCT, or just volunteering, but I feel like volunteering isn't quite as like hands-on or intensive as I want it to be. So like what would you recommend doing over the summers?
Yeah, absolutely. Become a CNA would be like fantastic experience. If you could have like 3 summers of working as a CNA, and even you could like work a part-time or per diem job like at the hospital here while you're going to school, work like 2 shifts like every 2 months or something. You kind of keep your hand in it. So the CNA is a certified nursing assistant. So in the inpatient units, the nurses have patients, and then there's several CNAs assigned to the patients too. They are such a big help. They do like so much to keep the floor running. So they are getting vitals all the time, blood sugars, like getting patients up and moving them. They don't do quite as much as the nurses, but if you want a taste of what nursing is like, become a CNA. It doesn't take long. I think you can do like a month-long class to get certified as a nursing assistant, and then you can get a job and they get paid pretty well. You know, it's not as much as nursing, obviously, but it's like a great job for when you're in school, and it's a good pay. It's just, that is a really good way to, without really, if you're not sure if you want to be a nurse, just go become a CNA, and that will give you a really good sense of what it's like. And without really being a big commitment of going to nursing school and then finding out that you didn't really like nursing. So if you don't like what the CNAs do, you're not going to like nursing. So definitely start there. That's like a fantastic place to start, and it will give you a really good sense. I'd recommend that to anyone. If you're interested in nursing, just take the month-long class, give it a try for a few weeks. If you hate it, you can say I'm moving on to a new career, but then you haven't wasted a lot of time. So. Yeah.
And then kind of along those lines, you said that nursing school was like really intensive and it wasn't really something that you were like expecting. What are some things that I could also do over the summer, or just like in general, to like, I don't know, like build up those skills and like that sort of like, not mindset, but like that sort of schooling, I guess?
Yeah. So being a CNA, that will kind of get you into like the medical world mindset, and you'll even be seeing how the nurses handle things and how they prioritize, and you know, how they make clinical judgments, because a lot of that is what they're looking for on the nursing exams. So if you can have some like hands-on experience and you sort of get in, like shift into that world, that's going to really help you. The multiple choice exams are what was really, really tough. So maybe if you could get like I don't think how to do this. Even online, you could look up like multiple choice or NCLEX style nursing exam questions, and you can kind of start going through them. Just like answer several a day, or you know, if you work on it once a month, like answer like 30 questions. You can look them up online. You can get like an NCLEX preparation book that it comes with like 1,000 questions that would be similar to what's seen on the NCLEX. Just start getting into, so do lots of practice tests. You could look up nursing school practice exam, maybe cardiac practice exam, and then it will give you a whole bunch of questions. Even if you don't know what it is, you start going through and seeing, oh, they're looking for that kind of answer. That's funny, they used that word, okay, that's why that was the right answer. And it starts to get you into that mindset, just shifting away from, like you were saying, in Christendom, we have the opportunity to explain ourselves and elaborate on this point or on that point if the teacher wants to see more, but you only get one shot with the multiple choice questions. So you have to really be, the wording is very precise, and you have to learn what to, the teachers are looking for as this correct answer. So if you could start doing practice exams, maybe buy an NCLEX book. They're not super expensive. You could probably buy one on Amazon and just start doing lots of practice questions. It will shift you into that mindset. Yeah.
Okay, does anybody have one last question to ask? Yes, up here. And by the way, I'm happy to purchase an NCLEX preparation book. I also have an MCAT study kit. I have MCAT flashcards. I've got LSAT flashcards. I have also purchased GRE books. So if there's something that you would need to prepare for any of these schoolings and careers, I would love to help you out and buy those resources for you that you can borrow from me. Okay, go ahead.
What advice do you have to patients who have spent a lot of time in the hospital who want to go into healthcare?
Wait, who want to go back?
So
Yeah.
patients who have spent time in the hospital and want to go into healthcare?
Yeah, so for example, people who've grown up their whole life with a lot of medical issues, who've seen a good variety, but not exactly sure where to go.
I guess think about why you want to go into healthcare. Has it been somebody that you had the best nurses, or a doctor that did something that really stood out to you, and you're that's it, I want to do that, I want to be that, and try and try and figure out what those attributes are about the people that you interacted with that really made your experience, obviously nobody wants to be in the hospital, but made it better than it could have been. And just kind of, try and figure out what those traits are and then emulate them. I know a lot of people from a PT standpoint who are I wanted to become a PT because I tore my ACL in high school and I had a great PT and that really inspired me. And it's that wasn't my story, but I can really understand how that can inspire you to want to change people's lives in that meaningful way. So I would just say kind of, go with, figure out kind of what area, I knew I didn't want to do needles. I did not want to give people, IVs and try and place that. I didn't want those 12-hour shifts, and I didn't want to go to med school for that long and do that journey. So kind of figure out what's important to you, work-life balance, and what you think your kind of avenue of healthcare that it really speaks to you, and what way that you want to give back, I guess, for all of the time that you had.
Yeah. Olivia, do you have anything to add to that for somebody who spent time?
Could you just
repeat the question?
Yeah.
the question? I was just wondering.
So she was asking for somebody who actually spent time as a patient in a hospital for several years of their life, and they want to go into the healthcare field. What would you recommend to them? Or what advice would you have for them?
Oh my God. Yeah, I think you'd be the perfect person because, like Emily was saying, you've been through it. And I think all of us have been on the receiving end of medical care at some point in our lives. But, volunteering, like they were saying, you can get a lot of experience to find out what field that you're interested in through volunteering, through shadowing. A lot of places are very open to having people come and see. If you're able to find some good mentors that are in different fields, like when I wasn't sure exactly what I wanted to do, I talked to dentists, I talked to optometrists, like eye doctors. Whatever interest I had, I would just try to ask questions. And also, working on working on yourself and being a well-rounded person, I think that's huge, no matter what you go into, whether it's medical field or not. Traveling can help you relate to people in so many different ways, or, if you like learning languages or whatever it is, even my English, major. I've connected with so many patients on that. So just having a lot of good life experiences, taking advantage of your time at Christendom, I think those can go a long way to help you. And like I said, with the medical side of things, just trying to figure out what you feel drawn to the most through either, experiences or talking to people in the field, I'd recommend.
Yeah, thank you. Okay, we are going to end there because I know it's already 8:30, I think, if I've got my time right. So thank you all so much for your attention. Thank you all for sharing so much information. Like I said, I think I asked you all 3 questions out of my at least 10 I have here. So if you all don't mind hanging out for just a little bit to maybe answer some individual questions, if you all wanted to talk to them, and we might have to have all of you back to do this again. So I was trying to think if there was anything else I wanted to say. I'll think about it. If you all will give them a round of applause and thank them so much.